Hello once again, and welcome back to Mondays on Mondays. This is the CDH Dad and
the CDH Warrior.
And once again, we're joining with you on Mondays to discuss issues related to families with children that have special needs, and particularly some unique health issues and how to deal with that as a family. Once again, just the general disclaimer is that we are not medical professionals. We do not have a background in medicine, but I do have almost 3 decades of dealing with children, my son being a congenital diaphragmatic hernia at birth, and then my daughter at less than 2 years old developing aplastic anemia and requiring a bone marrow transplant. So within the impact of those things, we've had to deal with a lot of the family dynamics of dealing with children with special health needs, and we just kind of have this forum so that we can discuss some of the topics that are concerns of how to handle a normal family life. So thank you once again for joining us.
And with that, let's roll the title.
And welcome back, everyone. As I've discussed in previous discussions that we've had, what we try and do is get feedback from you. We do have a email address, which you'll see on the screen at a later point in time, and we do take some questions from there. We also monitor a lot of the social media sites and discussions there and get involved with those. And that's how we come up with the topics that we're dealing with and discussing on these days. And one of the things that has been coming up this past week has been more of a topic we've kind of broached on in the past, but who handles the primary healthcare and decisions and the plan for a child with special health needs, and how do you deal with that? Particularly because in many cases what you're dealing with is doctors and medical centers and facilities and specialists in different locations, and sometimes they're not necessarily communicating well, and this is just a problem with the medical system and healthcare in general. It is difficult for these people, if they're not part of the same facility, to communicate back and forth and everyone getting the same information related to that. So I'm going to start with kind of an example. And in our case with my son was one that we did not know that my son had a diaphragmatic hernia prior to birth, even though we'd done ultrasounds and various testing just to assure that, we were going to have a healthy baby. The anomalies did not show up in such a point that it raised concern. Now, it's also one at that point in time was the technology with ultrasounds was not quite as advanced as it is now. I know at present with the ultrasounds, they can detect a lot of details about your child, internal organs, other medical issues that are concerns at 16, 20, 25 weeks. So that you have time to develop and put together a medical plan of how to go forward.
Yeah, now the technology's advanced so far that we can literally do 3-dimensional scans, complete 3D anatomy scans.
Right.
Of infants, and basically turn and twist just so we can actually see what's going on.
Right. You've got a lot of the computerized technology that you can utilize with this.
Yeah.
And in our case was one of going back. Yes, there were a couple of things on ultrasounds that might have indicated that there was a problem and concern, but it was also one, the technology was just, the films and the images were just so grainy and it was difficult to get a good clean shot of a lot of the anatomy, that it may have just been, the baby was in a bad position. So that's what was alluded to at that point. Now, as I said, part of what we want to do is kind of talk about how you handle centralizing the medical information and the medical care, and trying to deal with, in these cases, multiple facilities. In our case, my son was born at one hospital in Florida, and within a few hours was transferred to another hospital in Florida. We won't name that hospital, but...
Well, we'll name the city. Transferred from Panama City to Pensacola.
To Pensacola. And at that time, the hospital he went to had an older protocol that they utilized, which is, with a congenital diaphragmatic hernia, first step for a surgeon is do surgery and fix the problem. As we've discussed in cases now, most times now what is done is there's a protocol that was developed by Dr. David Case, who is pretty much the pioneer for the CDH protocol that's used now, and he was the doctor that helped direct a lot of these activities with my son. But we were fortunate in that the OBGYN that we had deliver my son had studied at Shands Hospital under Dr. David Case, and was familiar with the new protocol that he was developing.
Yeah.
And if I remember correctly, I think you were the 25th or 26th patient in that protocol study. So it was really in its beginning phases. But the OBGYN that we had in Panama City, as soon as my son was born, contacted Dr. K to let him know what was going on and try and feed as much of the information that he could that direction. And even though we weren't involved in this directly, Dr. K's at that time had an interest in CDH patients, and he was monitoring the progress all through this early stages of care. As I said, he was moved to Pensacola, was there for just a little over 12 hours. They did surgery there, and then very quickly had him transferred to Shands Hospital in Gainesville, Florida. So in less than 24 hours, he was in 3 different hospitals. But the key part of this, in terms of the health care that was being provided and how it was being provided, is the factor that the OBGYN that we had, even though we didn't know we had a CDH, was familiar with CDH, had worked under a doctor who was working on a protocol for CDH, and involved that doctor as basically a second opinion of what needed to be done, and to help oversee the care that was going to be taking place. And I had a chance to meet Dr. K's really about 48 hours after your birth, because I was able to spend a Saturday evening talking with Dr. K. And in your case, it was one that, as we talk about the concerns of what happens, is that the initial surgery did what was the typical protocol at that time, and opened up my son, went into his chest cavity and placed a patch over the diaphragm. Did not close up, did not do anything from that standpoint, just made the repair. Then he was shipped to Shands Hospital. As I said, about just over 48 hours after his birth, and almost exactly 48 hours after it had the repair surgery, his saturation points had dropped drastically. They'd been kind of borderline and been doing okay, thought everything was going well, and the next thing we know, within a few hours, my son is on ECMO, which is extracorporeal membrane oxygenation. It's basically a heart-lung bypass, and it's a machine that takes over blood flow and breathing for your child, and basically gives the heart and lungs a chance to recuperate, and the overall child to de-stress from childbirth and surgery and all of the trauma that comes about in those first day or so of this treatment issues. The reason I'm bringing this up, and what came up this last week, is an instance with a parent who learned at 20-something weeks that they were going to have a child with congenital diaphragmatic hernia, and had been referred to a hospital in the Midwest area, Ohio River Valley region. Had gone there, basically had a examination, determined what the status was, get more details, and then had gone back home. Now, while at home, there were some issues that came up. They went to their local hospital, and the local hospital basically did their examinations and found totally different indicators than the hospital that they had just been to. So this is where we're saying, there needs to be a point where there is someone who is a second opinion, but it's also there needs to be a lead medical professional that's overseeing this health care.
Yeah.
And this is one of the things that is very critical for a parent, is to work very closely with your doctors and your medical staff and learn who you can trust and how well you can communicate with them and discuss these things.
Yeah.
And I say this because we're talking about CDH, congenital diaphragmatic hernia, but also in the case of my daughter, she developed aplastic anemia very rapidly. From the first indications were less than a week that she was diagnosed with aplastic anemia, and was starting on treatment, and within just a few months it was necessary for her to have a bone marrow transplant. We had to oversee a lot of the steps and movements that were going in that. So a lot of times as a parent, you've got to listen very closely and pay attention to what the doctors are discussing, what information you're being provided, and discuss how this is. In her case, it was one that we had basically seen a lot of data and been told that if you've got a child that needs a lot of blood transfusions, after approximately 26 blood transfusions, it is not advisable to have a bone marrow transplant, because the blood system basically is not your own. You've been mixing numbers of different bloods into your body, and if you do that and then you put in the bone marrow, it becomes quite difficult, and you get heavy issues with graft versus host disease and rejection involved with this. So we knew that, and that was something that we had on our radar screen in the midst of the doctors that we were dealing with. And many times you're working with a teaching hospital, so you've got your doctors, but then you've also got the residents and interns that are also involved. They're just learning, and if this is something that's not atypical, they're not going to be up to speed on a lot of this. It's also an issue of however your medical system is put together. for us with the CDH, we knew that it was a pediatric surgical staff, but they were pretty much always available.
Yeah.
You know, different ones were on call at different times, but they pretty much overlapped in a lot of their activities.
You
One
still
doctor
had
may not
somebody
be,
over.
well,
Yeah.
one doctor was kind of overseeing things, but it was one that there was always a surgeon available, but the other surgeon, whoever was the primary doctor on this, was there to help provide the information and track the progress and provide their recommendation.
I think that was the nice thing in my case, was the fact that it was David, Max, and Dan. And all three of them were relatively well-versed, moderately versed surgeons at the time.
Well, it is, but it's also one
And
of...
could hand off to each other.
They could hand off the surgeries and things, but the primary care plan was one doctor.
Yeah.
And he would advise the other doctors what were needed. It wasn't that he overstepped his bounds.
No.
There may be other, he may be away, but another doctor doing the surgery, but they would check and find out what Dr. K may have recommended in that case.
Yeah.
In the case with my daughter, there were 3 rotating primary physicians in the hematology oncology group, and they rotated week to week. So you had a different primary doctor each week, and many times it's difficult for them to keep track of the progress, the situation, all of the details there. Then you throw in having to deal with residents and interns, and they're not necessarily tracking on those steps. This is where, as a parent, you need to keep track of a lot of the information. As I said, we knew that 26 weeks was pretty much, or 26 transfusions was pretty much a magic number for us that we kept track of. We were fortunate in that when we started doing the search, we found 2 umbilical cord donors, which were 5 out of 6 HLA matches. That's not perfect, but it's reasonably ideal to have 5 out of 6.
Is as close to perfect as you can get without actually being perfect at the time.
It was close. It was good. So we knew that we had stem cells that would be available if needed. But it was also one that we kept track of every transfusion. And as we got to that point of we were getting past 18, and we were looking at where the numbers were because we were having to have multiple transfusions a week. We actually talked with the unit clerk and had her go back through the records and verify that the numbers were right. And then we had to get with a doctor, one of the hemocs that we trusted, and present them with these numbers and discuss. And this is where you've got to have a serious sit-down meeting with your doctor, whoever it is that you trust and feel comfortable with, to discuss, okay, this is where we are and this is where we need to be, and where, how are we going to get there? Because at that point we were able to talk to a doctor who was able to look at the numbers, agree with what we said, and make the arrangements to go ahead and have a stem cell transplant. As I said, I'm fortunate in the fact that both of my children are in their 20s and reasonably healthy, which is quite unusual because with congenital diaphragmatic hernia, there tends to be issues with GI issues, respiratory issues, possible cardiac issues, reherniation, other things that come into play. We haven't necessarily hit those issues other than the patch did come loose just a few days after the first repair, but we haven't had that problem since. In my daughter's case, matter of fact, just today we were discussing the fact of there's a concern about she's at higher risk for cancer. she has had graft versus host disease, it's affected her skin, but not necessarily other organs. So she and I were discussing that, discussing with her doctor, since we have moved and she's got now an adult general practitioner who is her doctor, discussing these are the things that the doctor needs to be aware of and to look for in your case, because there may be that silent, distant sound of hoofbeats. You want to pay attention. It may be a zebra coming in and it will blindside you. So that's where the doctors need to know those types of things.
Yeah.
So that was part of the thing that we came up with the discussion today is it's critical to find a doctor that you feel comfortable with children with special needs and special health issues. It's not like you're going to have 4 or 5 doctors in your local area that specialize in these things.
Yeah.
What? How many hospitals are really CDH? Maybe a dozen?
I'll have to look back at the numbers, but
Rough number, though, is somewhere around 10 or 12 hospitals. That
well, within the southeast, if we count Cincinnati, since it's on the edge of being in Kentucky, there's 20 in the southeast.
Okay. So there's a few dozen hospitals in the country
Yeah.
that can handle that type of care.
The one issue you get to is, especially as you start going out west, they become more sparse.
Right. It's some of it's going to be a matter of population density. But what I was wanting to bring up is you will have to deal with making sure that doctors and medical centers in different geographic locations are communicating. And part of your responsibility as a parent and as a family member is to make sure that you're involved in those communications. And if you get that information and that you confirm that it has gotten to the people that need to know that, and then you may need to have serious sit-down discussions with those professionals of, okay, this is what I have, this is what I've read, this is what I understand. Do we agree that this is the situation?
Yeah.
And sometimes there are serious discussions that need to be had. And in our case, I know that with my daughter, we had to have a serious discussion one time, and I ended up calling in a patient representative with the hospital, basically a counselor who was helping us, and told them the situation, and they managed to get the medical professionals together so that we could all sit down at one time and discuss what the plan was. So these are the things you have to do, because yes, you're going to have to be pushy, but you are dealing with the life of your child. And in that case, you're not trying to make friends. You're trying to do what is best for your child and for your family and for yourself. So once again, we appreciate you for joining us on Mondays on Mondays. Have a great week.
Have a great day, and we'll see you next time.